So good evening, everyone, and welcome to Mahamana case discussion series. And today is the end of our 4 years of Mahamana, and next session will be the fifth year anniversary, and we'll be starting one. So thank you everyone for joining. Thank you, Paisa. Thank you, Deepa ma'am, for joining. And this session is on the skull-based tumors. And we have Dr. Deepa Nair with us. She is a professor in Tata Memorial Hospital, Mumbai, and she'll be speaking on the workup of the anterior skull-based tumors.
Can you see my screen?
Yes, ma'am.
Just hold on. I think I've uh once. Chrome was my PowerPoint, yes. Yeah, can you see my screen now?
Yes, ma'am.
Yeah, good evening, everyone. So this is a talk preceding the case discussion on anterior skull-based tumors. And just So the anterior skull base is basically a very complex area, and it has its own set of problems because of that. It is the watershed between the paranasal sinus and the brains, and we are dealing with two major special senses, that is the vision and olfaction. Now, because this is such a rare disease, it's less than 5% of all head neck cancer cases. You don't have a lot of guidelines as to how you should be managing these cases. And so a lot of whatever we talk about in the management of these cases is based mostly on retrospective data, mostly on eminence-based data, though now slowly collaborative studies and some few prospective trials are also coming forward for them. Now, what are the tumors which can affect the anterior skull base? And these are basically tumors arising from the skull base. A lot of these will be meningiomas and benign tumors, but the malignant tumors which we talk about are going to be things which arise from the neural crest, like the olfactory neuroblastomas. Most of the tumors normally which we deal with are paranasal sinus tumors, which arise from either one of the sinuses or from the nasal septum. Not very rarely, but we can get also metastatic deposits from other sites. And so what happens is there's a mixed bag of pathologies, and we can't follow a one size fit all criteria in this case. Some of the common PNS malignancies which we see in our practice are epithelial lesions, and the most commonest ones which we tend to see are squamous cell carcinomas. We also would see neuroendocrine carcinomas like sinonasal neuroendocrine carcinomas, neuroectodermal tumors like olfactory neuroblastomas or melanomas, and there's a whole range of newer entities which are being described like the NUT carcinoma, HPV-related carcinoma with adenoid cystic features, SMARC-B1 deficient carcinoma, SMARC-A4 deficient carcinoma, and so on and so forth. So before you actually plan treatment for these cases, obviously you need to work these patients up properly. And when a patient comes to us, apart from the history which we will take, what are the main things we talk about in history is obviously the patient will talk about nasal stuffiness, epistaxis. They may present with proptosis, with vision loss, with headache. Couple of things which you have to also talk or elicit a history is about sensation over the face, any nerve palsies, or anything which is causing the patients to have some sort of aspiration. That all is going to be some things which you need to elicit in the history. Uh, Diagnosis, the most important thing is your diagnostic nasal endoscopy. It is something which should be done in the OPD basis, except if you feel that the tumor is extremely friable or may bleed on touch. In such cases, then you would not want to do it in the OPD basis because you don't want to patient to have epistaxis there. Now, what are the things which we are going to look for in a diagnostic nasal endoscopy? We are going to try and identify where the tumor is coming from, and this is easy to do when the masses are small. So if you have masses which are arising from the nasal septum, a small nasal hemangioma, a smaller tumor, you can actually try and understand whether this tumor is arising from the middle meatus, lateral to the middle turbinate, medial to the middle turbinate. But more often than not, it may not be wholly possible on diagnostic nasal endoscopy because the mass may fill up multiple spaces within the nasal cavity. But more importantly, what is to be seen is tumor-free areas. Because remember, whatever imaging you may do, imaging always overestimates mucosal involvement. And because of the sheer structure of the ethmoids and the air cells in the paranasal space, a lot of these tumors hang rather than infiltrate the spaces in the nasal cavity. So it's important, especially when you are planning surgery for these patients, to do a diagnostic nasal endoscopy to look at tumor-free areas. And by these, what are we trying to look at? Whether the floor of the nasal cavity is free or not, whether nasopharyngeal mucosa is infiltrated or not, or the tumor is just protruding into the nasopharynx, whether the septum is infiltrated or not, and whether the disease is going upwards towards the cribriform area. And obviously, the nasal endoscopy will help you target a biopsy for the patient. In the workup, you always have to complement your tissue diagnosis with imaging. Now, the imaging, what we are going to do is both CT scan and MRI for these patients. And this is basically a complementary imaging. You need to know the soft tissue extent, you need to know the bony involvement. And these are important because one, MRIs give better soft tissue delineation. It may also help you identify or talk about some sort of tumors. We classically know that T2 weighted images will help us distinguish between tumor versus secretion, which a CT scan may not be able to do completely. But more importantly, CTs are important, especially if you have tumors which have chondroid or osteoid component in them. It will give you sort of a hint that you are possibly dealing with a mesenchymal tumor when you look at osteoid matrix or chondroid matrix within the lesion on the CT scan, which, yes, on an MRI, a good radiologist will be able to suggest, but it's better seen on a CT scan. More importantly, when you are planning surgery for these patients, it will tell you, the CT will give you a more a good approach whether you can offer this endoscopically, what are the involvement, what is your Kiros classification when you have tumors reaching the cribriform area, when what is the position of the lamina papricia, which on the MRI may be difficult to understand. It helps you decide resectability, your surgical approach, and ideally, if you have a tumor which you're not sure where to target from, then an image-guided biopsy is warranted in those cases, especially for submucosal lesions or difficult to reach areas. Uh, it also gives you an idea by bone destruction versus bone remodeling, suggesting the grade of the tumor. If you have a tumor which is large, but you can see scalloped bones, you can be reasonably sure that this is going to be either a benign tumor or a low-grade malignancy, because remodeling happens only when the tumor is long-standing and slowly growing, whereas bone destruction happens in more invasive tumors. And if you have a hypervascular tumor, if you have a glomerulonephrocytoma, if you have a JNA, in those cases, you may want to do a preoperative angiography with a balloon test occlusion. Like I told you, CT scan is best for the bony anatomy, and you can do it very fast. It allows multiplanar reconstruction and again helps you see the perfusion status. The bone changes help us, as described before, for determining aggressive versus slow-growing lesions. MRI is invaluable when you're dealing with these tumors because this gives you above and beyond what a CT can tell you, especially when you're dealing with the skull base per se. It tells you about dural involvement, leptomeningeal involvement, cranial nerve enhancement, perineural spread, infiltration of the bone marrow. And here, these are a couple of images which you can see that you can, and you need to look at all the images. You need to look at T1 plain, you need to look at T1 with contrast, you need T2 plain, T2 fat suppressed, T2 with contrast. All of this give you better delineation in and in multiplanar imaging. You need to look at axial, corneal, and sagittal scans to exactly understand the extent of the tumor. If you see in this case, this arrows pointing to the dural involvement. Again, one of the ways to differentiate with the dura is reactive or infiltrated is enhancement of the dura is reactive or infiltrative is by looking at whether there's nodularity. So linear in dural enhancement generally is just inflammatory, and that may happen because of the sheer abutment of the tumor to the dura. However, if you have nodular thickening as seen in this case, then you know that the patient will have intracranial, dural involvement, and you have to prepare for resection of the same. Again, with respect to the orbit, it would be very important to look at T2 weighted images, not just the CT scan, and it helps you identify whether tumor, which is intra orbital, is actually intraconal or extraconal, as you can see here. Here, the periorbital fat seems to be involved, but the tumor is still outside the cone of the orbit. So this is a checklist, and let me just go back. And this is a good article by Richard Harvey et al. In 2017, OCNA, and they talked about what is the checklist you should do and what you should be looking at in the scans whenever you have patient of sinonasal tumors, and what you have to look at. So in the CT scans, you would look at expansion, you would look at the foramen, you would look at normal anatomy and involvement of the hard palate, whereas in the MRI, you would look at fat sat, post-gadolinium scans, and you would look at all of these things which we've already discussed. What about biopsy? Imaging and good radiologists will be able to really tell you that possibly this looks like a chondrosarcoma or this looks like some other tumor. But sometimes, I mean, not sometimes, a lot of times in carcinomas, the imaging will not tell you whether it is a olfactory neuroblastoma or it is a sinonasal carcinoma, it's an adenocarcinoma. The radiologist can give you a hint, but you obviously need tissue diagnosis for your treatment strategy. If you have vascular tumors on the scans, it's better to avoid a biopsy. And if you see a patient in the OPD who has something which looks vascular or has had many episodes of bleeding, in such case, I would always recommend first do the scans and then do a biopsy. It's good practice to have the scans when you're doing a biopsy for a couple of reasons. One is obviously the vascularity of the tumor. It will give you an idea. Secondly, a lot of times when the patient comes to the OPD or the outpatient clinic, there's a lot of necrotic component anteriorly and polypoidal tissue, which we may biopsy. But you need to really correlate with your scans. And this polypoidal tissue will come as inflammatory polyps on your on your histopathology, which will not give you a diagnosis. So if you have the imaging, which will tell you that yes, the actual enhancing part of the lesion is much deeper, you can plan your and target your biopsy appropriately. Also, if you do a biopsy, there will be a lot of inflammation, which if early MRI is done after the biopsy, may overstage the disease again. And the role of doing a biopsy before or doing an excision biopsy, I would always advocate for a biopsy to ideally identify what the histology is. Please do not go and plan surgery for every patient who you see with a nasal mass. Some of these patients may be chemosensitive, some may be chemoradiosensitive, and you may not need to offer them surgery at all. So always do a biopsy and then plan treatment for these cases. Again, you can, most of the times, these lesions are accessible by endoscopy to do a biopsy in the minor operation theater, in the outpatients, if you have a good setup with where you have a suction and packs ready for in case of bleeding. But we prefer in our setup to take it in the minor operation theater. because of this chance of bleeding, and which may be sometimes uncontrollable in the outpatient setup. If you have a lesion which is not easily targetable, it's more situated within the maxillary sinus or involving the infratemporal fossa, then a guided image biopsy is always better to be done, and avoid necrotic tissue as far as possible. What about PET scan? So for most of the cases, a PET scan is only done to look at the presence of distant metastasis. The initial workup or the primary tumor imaging still remains a CT scan or an MRI. The PET is mainly for ruling out distant metastasis at presentation in case of aggressive histologies like sarcomas, malignant melanomas, undifferentiated carcinomas, neuroendocrine tumors. But you can use it uh, after during treatment to look at response if you have given induction chemotherapy or CT chemoradiation, and for follow-up of patients to see whether there's recurrence of disease. It's imperative to document cranial nerves and the vision of the patients, and sensory special sense testing is mandatory. We don't do it very often. I think most of us would be documenting vision in the patients, but we don't really focus on olfaction, and that's something maybe we should be looking at. So you should document baseline olfaction and vision preoperatively. And this is important because some of these visual defects may be reversible if you can decompress early. And also, before and after surgery, the assessment of vision before radiotherapy and after radiotherapy is important so that the patient as well as the clinician is aware of what are the deficits and what is the response to treatment in these cases. I don't think I need to speak to this audience about the different types of testing of the cranial nerves, but just a checklist of what you can do in the outpatient departments to assess each cranial nerve for this patient. Very important, not just assess, but document it in your systems. Ophthalmology evaluation has to be done mandatorily in all cases, irrespective of involvement of orbit or not. And that is because most of these cases, especially malignancies, will have some amount of orbital involvement. Even if they do not have orbital involvement, the treatment itself may have some impact on orbit as well as the optic nerve, especially when you plan surgery in these areas or you're planning radiotherapy. You need to have a complete visual examination, perimetry if you're having lesions, posterior based lesions, if you're going to do radiotherapy, which will treat the optic apparatus. In such cases, not just visual acuity, motility should be done, but also you need to have a document baseline cataracts present or not, whether the lens is clear or not, what is the visual fields of these patients, because all of this can be impacted by your treatment. And it's good practice to document it pre-operatively, do some corrective measures if required, and have post-treatment documentation again so that you can keep these patients on follow-up. And also it helps in counseling of these patients. It helps in your decision making, especially when you have orbital involvement. You need to be sure. Sometimes if the patient has loss of vision in one eye due to a cataract or an injury, and the normal eye is the one which will potentially get affected by treatment. Like if the tumor is involving the orbit and the patient is only seeing with the same eye, in such cases, your surgical decision may completely change to a non-surgical modality in a way to preserve the eye. So these are the important things which we don't realize in day-to-day practice, but it's very important that a lot of your treatment planning will depend on what the functional status of the patient is. Coming to staging, staging of the paranasal sinus tumors are basically, as per AJCC and UICC, divided into mainly from the maxillary sinus and the nasal cavity and ethmoid sinus. I think all of you all know about it. Most of these tumors are, if they are restricted to one site without bony, with or without bony invasion, they are called T1 lesions. In the nasal cavity and ethmoids, more than one subsite involvement or Involvement into the nasoethmoidal complex is T2. Involvement of the medial wall or the floor of the orbit, maxillary sinus cribriform plate is T3. And anything which involves anterior orbital contents, skin of the cheek or nose, and minimal extension to anterior cranial fossa becomes T4A. But anything going into the orbital apex, the middle cranial fossa, and nasopharyngeal clivus becomes T4B in these cases. Nodal involvement is just as the others. So lastly, I just want to briefly tell you why it's important to have histology and before you plan treatment for these patients. And that is because if you see, every histology has a different sort of treatment philosophy. When you have squamous cell carcinomas, generally the accepted treatment is radical surgery plus radiotherapy, and you would electively irradiate the neck, especially in T3, T4 lesions, because there's a high incidence of lymph node metastasis, more than 20% upwards. Whereas in adenocarcinoma, if you have low-grade tumors, which are T1, T2, only surgery may suffice in these cases. That it's the T3, T4, the high-grade tumors where you would consider surgery followed by adjuvant RT. There is no, you do not irradiate the necks electively because the risk of regional metastasis is low. Similarly, for olfactory neuroblastoma, the treatment would be a combination of surgery with radiation and chemoradiation. Sometimes in high grade, high stage tumors like a Hyams grade 3, grade 4 tumor or a Kaddish C tumor, you would start with induction chemotherapy and then treat it based on the response to chemotherapy with either surgery followed by chemoradiation or chemoradiation. Again, neck irradiation is propagated in patients with olfactory neuroblastomas because they tend to have late failures both regionally and distantly. So in most cases who are Kaddish C, elective neck radiation of the even in N0 patients is offered. Similarly, for neuroendocrine carcinomas, aggressive multimodal therapy with a combination of neoadjuvant chemotherapy followed by either CTRT or surgery is generally offered to these patients. In sinonasal undifferentiated carcinomas, which now the bag has become very small with the identification of newest pathologies, the treatment modality is generally concurrent to chemoradiation followed by salvage surgery. So I think what are the important key factors in workup which help you make your decision is the presence of intracranial disease, the present extent of intradural disease, the presence of orbital involvement, infratemporal fossa involvement, what is the tumor histology, what was the previous treatment, and these are things which you should incorporate and look for when you're planning these cases. Thank you very much. I think most of the questions answers can be also taken up in the um, case discussion, I think. Back to you, Asim.
So thank you, ma'am, for the wonderful talk. If there are any comments or any questions, you can put it in the chat box and we can discuss it during the case presentation. So we'll move ahead with the case presentation now. And for the same, we have Dr. Areej Moideen. She's a resident at All India Institute of Medical Sciences, New Delhi. And I'd like to invite all the examiners, Dr. Prathamesh Pai, sir. He's a director and chief consultant at PT Hinduja Hospital, Mumbai. Dr. Kaberi Kakati, she's a professor in Department of Ethnic Surgery at B. Barua Cancer Institute, Guwahati.
Hello.
And Dr. Shwetabh Sinha, he's associate professor in radiation oncology at ACTREC, Mumbai. And Dr. Smriti Panda, she's an associate professor in All India Institute of Medical Sciences, New Delhi. And I'll also request Deepa ma'am to please join in for the case presentation. Areej, you may please start.
Good evening, sir. Is my screen visible?
Yeah,
Yes,
we can
yes.
hear. We can see you and hear you.
Okay, sir. Good evening, respected teachers. So I'll be presenting the case on anterior skull-base malignancy. So my patient is a 26-year-old gentleman. He is a resident of Bagpat, Uttar Pradesh. He is farmer by occupation, who had presented with chief complaints of left eye decreased vision for 18 months, left eye complete loss of vision for 7 months, left eye swelling for 4 months, left nasal obstruction for 4 months, left facial numbness for 4 months, history of occasional nasal bleed for 1.5 months, and right eye blurring of vision for 1.5 months. So, history of presenting illness. My patient was apparently normal 18 months back when his complaint started as decreased vision of the left eye, which was insidious in onset, and it was gradually progressive to have complete loss of vision on the left eye for past 7 months, and it has progressed to have blurring of vision on the right eye for past 1.5 months. It was associated with left eye protrusion for 4 months, which was painless in nature. He also had complaints of left nasal obstruction, which was insidious in onset, and have progressed to have loss of smell at present. He also complains of numbness over the left side of face for past 4 months, and history of occasional nasal bleeding from the left nostril, which was scanty in amount, which subsides spontaneously. And he also has complaints of frontal and left temporal headache, which is dull aching in nature, constant with no diurnal variation, which was disturbing routine activities and currently requiring pain medication. There is no history of watering from bilateral eyes or double vision, no history of protrusion of in the right eye, no history of nasal obstruction, right-sided nasal obstruction, nasal discharge or nasal bleed, no history of facial swelling, loosening of teeth, bulge or ulcer in the oral cavity or decreased mouth opening, no history of watery nasal discharge, fever, vomiting or seizures, no history of any ear discharge or decreased hearing, no history of any neck swellings, no history of cough, pain abdomen, jaundice or bony pains, or no history of any significant weight loss or loss of appetite. Shall I proceed, sir?
Yeah, go ahead.
Uh,
Okay, so you have got no other history. So let's go back to your first slide.
Yes.
So what is it that you expect when you have got these chief complaints?
Sir, it started as a he had complaints started in the eyes, which has again gone into the opposite eye. He had eye swelling. Along with that, he has nasal obstruction and facial numbness.
Right.
So it gives a history of possibly of a posteriorly located lesion higher up at mostly at the orbital apex region, sir.
Intraorbital or orbital apex.
Sir, initially it might have started at one orbit, then it have progressed towards the orbital apex because he has complaints of the opposite eye as well, sir.
So the
And-
predominant symptom here is vision loss.
Yes, sir.
So his vision started deteriorating 18 months ago. That was his first symptom.
Yes, sir.
So what would you suspect when you have this kind of presentation? It's a very long course.
Yes, sir. So it can be any tumors of the optic nerve, which was it can be a slow growing tumor of the optic nerve, can be a meningioma, maybe, sir. And because we see there is maybe it has progressed so that he has complete loss of vision after 7 months. But then he started having nasal complaints along with proptosis, which gives features of a pushing tumor which is pushing the eye laterally. So
now let's go to the next slide. So then you ask a couple of questions. Go to the next. You asked a couple of questions. Now, will you lead us as to why did you ask and what was the reason for asking all these questions?
Yes, sir. So there is no, I asked for watering from bilateral eyes to look for any nasolacrimal duct obstruction. And double vision, sir, he's blind in the current. He does not give history of double vision previously because the proptosis started later on after he was completely blind. So there is no history of double vision. And there is no protrusion of the opposite in the right eye. So we get a history that maybe there is the pressure, which is, there is a tumor maybe in the right side, which might not be causing that much compression, might causing a proptosis.
So now when you discussed earlier, you said that you had some sort of an idea that it has to be something posterior. It
Yes,
has to be something that is gradual. It
yes,
has to be something that has now led to a complete obstruction of vision.
yes, sir.
Now, when you are asking history taking for this patient, it should be something relevant to this. You
Yes, sir.
started from anterior, you went on to protrusion. Now, is there something else that you would want to ask before? Like you said, you were suspecting a meningioma.
Okay,
You're suspecting something intraorbital. You're suspecting something intraneural. So
yes,
there should be things that you need to ask which are corroborating your history rather than go in a checklist manner.
sure, sir.
So what is it that you would like to ask this patient?
Uh, Sir, history of any headache or orbital pain, retroorbital pain,
Right. What
and
else?
and any
So some things that are going from the cranial cavity down, something that is going intraorbital out, something that is going within the globe. So you have to ask those histories. So is there a history of headache? Is there a history of vomiting? Is there a history of, go back? Is there a history wherein this patient has a visual, where he has visited the ophthalmologist for various other complaints like a increased pressure? All those things would give you more idea rather than go directly to the nasal component or the maxillary component.
sir.
Okay, go ahead. Why did you ask the others now? Other questions?
Sir, history of right nasal obstruction, nasal discharge to see check for complaints of the opposite nasal cavity, and history of facial swelling, loosening of teeth, bulge or ulcer in the oral cavity to see whether the tumor has, if mass has extended to the maxillary sinus and it has gone into the hard palate causing loosening of teeth or bulge or ulcer. If it has gone into the infratemporal fossa, patient will have history of trismus. So I asked for decreased mouth opening. And if he had also complaints of headache, so to check for any features of meningitis, I asked for history of any watery nasal discharge for any CSF leak or fever or vomiting or seizures. And history of ear discharge or decreased hearing if it is obscuring the nasopharynx and causing blockage of the eustachian tube, patient will have oral fullness and may have, if progress, can have decreased hearing and otitis media with effusion. So I asked for ear discharge, sir. And if the tumor, if we are, if it is a sinonasal tumor, if there is extension into the neck, so neck nodal mets, for that I asked for the neck swellings. And for distant
Okay.
metastasis,
So have you localized the lesion now with the history?
Sir, from the history, I feel it's a posteriorly located lesion, mostly ethmoidal lesion, and it has it it has history of. He also, maybe from history wise, he's giving complaints of headaches, or maybe can have a component of intracranial extension, maybe, sir.
Okay. Anyone else would like to add?
Aris, in your presenting history, you mentioned that patient has got the numbness over the cheek.
Yes, ma'am.
So, if your lesion is located in the ethmoid, so what can be the mechanism for that?
Ma'am, it can be at the posterior, it can be through the inferior orbital fissure or through which the inferior orbital nerve comes rather than at the maxillary orbital rim. which we see in the maxillary tumors. That can be a cause, ma'am.
Okay.
So what I would like you to do is also when you are trying to localize,
Sir.
as you heard Deepa speak about the complete examination.
Sir.
So you need to ask, you had a numbness of the face. You have not talked about the movements of the eye. So was there any change in the patient's eye movements? So any history of restricted eye movements, because that will tell you about the intraorbital, the contents, whether the contents of the orbit are involved.
Sir, actually, the patient presented was with PL negative status of the left eye, so he could not appreciate any movements of the left eye, sir.
Okay. Okay, go ahead.
Past medical and surgical history, there is no history of similar illness in the past, no history of diabetes, hypertension, ischemic heart disease, tuberculosis, or any other comorbidities, no history of surgeries or any prolonged hospital admissions.
So these are you need to tailor make it. You certainly can't say no history of similar illness in the past. What illness in the past would have caused a blindness and then recovered?
Sir,
So pay attention to these things because we present this at the spinal level,
sir.
and these are not things that are important. So it honestly leads to some embarrassing questions being asked like this.
Okay.
So focus on what exactly you want as far as your medical and surgical history is concerned,
Sir.
and then focus on that.
Sure, sir.
What surgeries would you expect this patient to have had?
Whether sir, it's long-standing history, whether he had any history of any sinus surgeries.
How old is the patient?
26, sir.
So at 26, what do you expect this patient to have had, which could have been significant for us?
Sir, whether any acute sinusitis causing orbital cellulitis, but then there is no history like that, sir. There is no history of any painful red eye or
Any nasal surgery is
yes.
important. So any nasal surgery, any intraorbital surgery,
Hmm.
any dental work, any
Sir.
trauma of the midface or any infection in the past for any hospitalization.
Yes, sir.
For then you are certainly want to know about his blood sugar levels and if there's any other illness like
Immunocompromised
tuberculosis.
state, sir.
Yeah, like a compromise, comorbidities and any immune compromised states.
Yes.
Okay, go ahead.
Personal history, he's a farmer by occupation. He has a mixed diet, good appetite, bowel and bladder habits are unaltered. Addictions, he has history of VD smoking, 4 to 5 per day for 3 years, and he has abstained since 2 years. There is no family history related to any family history of any cancer or.
So can you tell us something about what occupations are related to the skull-based tumors?
Sir, exposure to inhalational dust by wood, textile industry, and chemicals like nickel, chromium, and formaldehyde, sir.
Okay.
And paint also, sir.
Right. Okay, go ahead.
So to summarize, my patient is a 26-year-old farmer who is a BD smoker who presented with history of progressive vision loss in the left eye for 18 months with complete blindness of the left eye for 7 months with associated left proptosis, left facial numbness, left nasal obstruction and nasal bleed and loss of smell for 4 months and right eye blurring of vision for 1.5 months.
What is your diagnosis?
Sir, it can be a sinonasal tumor, most likely a ethmoids. I would consider ethmoid as the site. And due to its progressive nature, I would think of malignancy first.
Okay, go ahead. 18 months history, so it is not really very acute. Okay, go ahead.
General examination. Patient is conscious, cooperative, and well-oriented time, place, and person. He is moderately built and nourished. He has an ECOG performance score of 0. His height is 172 centimeters, weight of 72 kg, and a BMI of 24.3 kilogram per meter square. There is no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, or pitting pedal edema. Patient has left eye non-axial proptosis and swelling over the left upper eyelid. Vitals, pulse rate is 84 per minute, regular. Blood pressure is 120 over 88 millimeters of mercury, right arm sitting position. Respiratory rate of 16 per minute, regular. And he's afebrile. Coming to systemic examination. Central nervous system, he is conscious and well-oriented to time, place, and person. Coming to cranial nerve examination, olfaction was absent in both right side and the left side. Optic nerve vision was 6/9 on the right and PL negative on the left side. 3, 4, 6 cranial nerves was normal on the right side. Left side, there was restriction of movements on medially. Rest all movements were full and free. Pupillary reflexes were normal. Trigeminal nerve was normal on the right side. On the left side, there was decreased sensation of touch and pain and temperature over the left side over the V2 area, sir. The corneal conjunctival reflexes were normal. 7 and 8 cranial nerves were normal. Lower cranial nerves were also normal bilaterally, sir. So he had an abnormal olfaction, optic nerve of the left side, and restricted eye movements medially on the left side, sir, on cranial nerves. Sensory, motor, and cerebellar signs were normal. Cardiovascular system, both heart sounds were heard, no added sounds. Respiratory system, bilateral normal vesicular breath sounds heard. Per abdomen was soft and non-tender. Coming to local examination. Examination of external nose, skin, and both bony and cartilaginous framework appears to be normal. There was no swelling or scars noted. On anterior rhinoscopy, there was a bony spur to the left and a right inferior turbinate hypertrophy was there. On direct nasal endoscopy, on first pass, both the nasal floor, nasopharynx, eustachian tube opening was normal bilaterally. On second pass, there was proliferative mass in the sphenoethmoidal recess, which was bleeding on touch. On probing, the probe could be moved all around the swelling and seems to be appearing from the roof of the nasal vault and on the right side. And same finding was found on the left side. On third pass, on examining medial to the middle turbinate, it was normal on the right side. On the left side, there was mass present medial to the middle turbinate, distorting the middle turbinate. There was, however, no discharge or mucus plug noted in the nasal cavity, in the endoscopic examination. Examination of paranasal sinuses. There was tenderness present over the left ethmoid sinus region. However, no other paranasal sinus tenderness could be elicited. Coming to examination of orbit, on inspection, there is left non-axial proptosis noted, and the left eyeball was placed downwards and outwards. On inspection, there was an erythematous swelling over the left upper eyelid. On palpation, inspectory findings were confirmed. There was no local rise of temperature or tenderness over the bony or orbital rim without any discontinuity or thickening. The palpebral aperture was symmetric. On the left upper eyelid, there was an indurated swelling measuring about 2.5 into 0.5 centimeters, which was non-tender with no local rise of temperature, firm in consistency. Skin over the swelling was non-pinchable. The conjunctiva sclera and cornea was normal bilaterally. Extraocular movements was restricted medially on the left eye. Rest all movements were normal bilaterally. Bilateral pupillary reflexes were normal. Bilateral corneal and conjunctival reflexes were normal. On local examination, examination of oral cavity, mouth opening was inter-incisors distance was about 4 centimeters. It was a dentate mandible. There was no sharp tooth, dental caries or loose tooth. Tongue movements were normal. Examination of oropharynx was also normal. On examination of ear, bilateral tympanic membrane was intact. There was no cervical lymphadenopathy, and examination of larynx showed a bilateral true vocal cord were mobile.
Okay. So go ahead. What will you do for this patient?
Sir, I'll first go for imaging of this patient to see the extent of the disease. Imaging, I would like to get both non-contrast computer tomography of nose and paranasal sinuses, along with CMRI brain orbit, contrast enhanced MRI of the brain orbit and PNS to look for the extent of the tumor, the vascularity of the tumor, and to look for the representative site from which I can go for a biopsy. And once along with biopsy, I would like to do an immunohistochemistry as well to look for the exact type of histology which we have.
Okay. So let us see the scans. Let's show the CT scan first. So can you read the scan for us?
Yes. So it is a contrast enhanced computer tomography showing axial sections showing going from craniocaudally. So when we go above downwards, we can see heterogeneous enhancement filling the left frontal sinus. And on the next scan, we can see there is erosion. There is a soft tissue intensity, soft tissue mass in the left medial wall of orbit, which is extending along the anterior aspect of middle, going posteriorly, and we can see it going into the lateral aspect along the middle cranial fossa as well. Going further down, there is heterogeneous enhancement of the bilateral ethmoids as well. And when we're further going down, there is tumor in the nasal cavity and obliterating the middle meatus, sir.
Okay.
And on the coronal section, when we can see there is mass in the bilateral sphenoethmoid recess. There is tumor obliterating the maxillary sinus ostia. And then going posteriorly, we can see tumor obliterating the orbital apex. There is some amount of soft tissue seen in the right orbit as well. And there is obliteration of there is soft tissue density lesion in the sphenoid sinuses, which are obliterated. And posterior choana and seems to have the soft tissue density mass as well. And here also we can see in the coronal sections also we can see there is involvement of the middle cranial fossa, and the carotid seems to be, there is some amount of involvement of the internal carotid arteries.
Okay. So when you're seeing the scan, what is it that is striking for you? What is it that has caused all these symptoms for the patient?
Sir, it is the lesion is at the orbital apex, sir, and the middle cranial fossa.
It's more of a paracavernous spread.
Yes.
But the sinuses per se don't look
There was
involved.
no erosion, yes, sir.
Yeah, and there is some thickening of the bones at the nasoethmoid junction also.
Yes, sir.
Okay. Let's see the MRI. So this, we have only 3 sections.
Sir, I am.
3 images. Okay.
Sir, can I share the packs? I have the packs, sir. I'll share the packs.
Yes, please, sure. Please, sure. Kaberi, Shwetabh, Any questions?
Yes, sir.
Yes, sir, we'll see the scans.
Areez,
Yes, ma'am.
you initially said, hi, Areez.
Yes,
You
ma'am. Yes,
initially
ma'am.
said the tumor was on the ethmoids, right? I mean, you expect the prime.
Yes, ma'am. Hello, ma'am.
Yeah, go ahead. Go ahead.
Yes. Sir, this is T1 contrast showing contrast enhanced MRI showing the axial section, sir. We are going craniocaudally, and we can see there is enhancement mostly. So it is sinus enhancement of the left frontal sinus. Some amount of edema is seen over the left uh, cerebrum area. And going down, there is a soft tissue intensity lesion pushing both the ethmoids more on the left side, causing pushing the orbital optic nerve. And it is extending posteriorly into the middle cranial fossa and along the cavernous sinus.
Right.
Ethmoids, because the walls are maintained and there is sinus thickening, sir, mostly.
Right. And what else? So what is it that you should be looking for on the MRI? You heard Dr. Deepa Nair's
Yes.
talk.
So we look for the orbital apex. We look for if there is involvement of the cavernous sinus. We look for whether there is internal carotid artery involvement, how much of the brain is involved, how much of intracranial extension is there. And we look for any if there is any retropharyngeal lymph nodes involved, if there is tumor extending into the infratemporal fossa. And if extending into the tumor, we try to look which part of how much of the orbit is involved, whether it is just the periorbita or if there is involvement of the medial rectus and the intracorneal component compartment of the eye as well.
What else? What are the signs of inoperability?
Sir, signs of inoperability, if there is gross intracranial extension, if there is involvement of the internal carotid artery, involvement of the orbital apex, and involvement of the orbital apex in internal cavernous sinus, internal carotid artery, and cross intracranial extension, sir.
Yeah. So in this, what is it that we are seeing?
Sir, we are seeing cavernous sinus is involved, sir. The orbital.
Sorry.
Sir, cavernous sinus is involved, sir, and the the intracranial, there is intracranial extension as well, sir, of the middle cranial fossa.
Right. Right. So what is the what will you do next for this patient?
Sir, once we have done the imaging, we'll go for a biopsy, sir. And
Yeah. What kind of biopsy will help in this patient?
endoscopic guided biopsy, sir.
So where would you take the biopsy from? Here. Where is the lesion seen?
Sir, bulk of the lesion is seen in the left sphenoethmoid recess, sir.
Okay.
So we'll take a biopsy from there, and based on the biopsy report, this is imaging wise also it is a T4B tumor, sir.
Right.
So we'll wait for the biopsy, and based on the biopsy report, sir, we'll plan the patient for neoadjuvant chemotherapy.
So what while you're waiting for the biopsy, what would you like to do for this patient?
Sir, I would like to check whether patient is having any symptoms of intracranial raised intracranial tension, we'll get a visual eye ophthal documentation done. We look for the fundus examination. We look for there are any features of raised intracranial pressure. And if is as per the scan, there is no features of midline shift, but then we would like to, but he has symptoms of headache, so we will like to start him on anti-seizure medication and anti-epileptics as well as mannitol, sir.
Right. So you took a biopsy?
Yes, sir. And
Okay.
and we also, to rule out as it is an advanced stage tumor, I would like to look for any distant metastasis. So we'll go for a whole body PET scan, which was done in this patient and did not show any features of distant metastasis. And biopsy showed a nut cell carcinoma, sir. Nut carcinoma.
Okay. And what was the immunohistochemistry done on this?
Sir, it was we looked for the fusion molecular testing was done for the fusion protein of nut and DRB4 fusion proteins.
Okay.
Hello?
Yes, ma'am.
Yeah. So how do you proceed? I mean, you have done nut cell, the histopathology is nut cell. So any other tests you want to do on the histopathology or something? You told something about IHC, correct?
Yes, ma'am.
In the beginning. So
yes. So we look for the nut pattern. You will put the speckle pattern will be seen, ma'am, in nut carcinoma. Other than that, you look for the fusion protein of nut with DRB4 fusion protein, ma'am.
So how would it help in our management?
Ma'am, it will just confirm the diagnosis, ma'am. Nut is a very aggressive tumor, nut carcinoma. So it will only confirm that it was initially considered, it was classified under synovial undifferentiated carcinoma, but it helps to diagnose this as an aggressive variant.
Okay. So how do you proceed?
In this patient, he has symptoms of the opposite eye. So to preserve the opposite eye, we'd like to plan initially for neoadjuvant chemotherapy and followed by response assessment.
Okay. How sensitive is nut cell carcinoma with chemotherapy? I mean, you want to preserve the orbit for what? The opposite orbit for surgery or for radiation or for what?
For not for surgery, ma'am. It is for it will be management will be
So
not.
what is your intent of giving an anesthetic?
Ma'am, intent of giving NSCT will be to reduce the tumor bulk and reduce the pressure reduce the tumor bulk and decrease the compressive symptoms of the right orbit, so that we can preserve the vision of the right orbit as he is already vision depleted on the left.
What is the incidence of sensitivity of chemo to nut cell carcinomas? How sensitive is nut cell to chemo?
Ma'am, it is. I'm not sure of the exact percentage, ma'am, but I know we.
So, Areej, what is your intent of treatment in this patient?
Sir, as he has a good performance score, he's a young patient. My intent will be curative, sir. And
so you first told me that this patient has some signs of inoperability.
Yes, sir.
What were those signs?
So there was tumor extending into the orbital apex. There was tumor involving the middle cranial fossa. There was involvement of the cavernous sinus, and partially there was involvement of the internal carotid artery, sir.
So is this curable?
Sir, we can try a course of NACT and see, sir. After
No, not try. I'm asking you, is this curable or incurable?
It's not curable, sir.
Not curable. So what should be our intent of treatment in this patient?
Palliation.
Palliation. So you have to be very clear when you're asked what is the intent? You have to be very clear as in terms of the tumor extent, in terms of the biology of the tumor,
Yes,
what
sir.
you can possibly expect.
Yes,
You
sir.
said this is a high-grade tumor.
Yes,
You said that this is inoperable disease.
sir.
You know that in those areas you cannot achieve a clearance in a high-grade tumor, which is relatively less chemosensitive.
Yes, sir.
So our intent of treatment will become palliative.
Yes,
Now, Dr. Kaberi Kakati asked you, what is the sensitivity of this to neoadjuvant chemotherapy?
sir.
So we know that this is relatively less sensitive.
Sensitive. Yes, sir.
We also know that there are certain other markers which we would want to do to know
Socks.
for whether there is a sensitivity pattern.
Okay, sir.
Uh,
Like socks 10.
yes. So we would need to know about the sensitivity of chemotherapy.
Yes, sir.
Now, is this radio sensitive? Is this sensitive to radiation therapy?
Sir, they are not very sensitive, sir, but
Okay. Shwetabh, any thoughts?
Yeah, I think first of all, I will agree that in my opinion, this is palliation, and it is not, as you correctly said, it's not even a very sensitive tumor. So I don't think that radiotherapy is going to be of much help for this patient. I mean, sir,
Shwetabh,
do you
you're
have any
breaking.
different opinions?
No. You're just breaking. We could not hear you clearly. That's why I'm asking.
Sorry,
you
am I audible now?
be more clear?
Am I audible now?
yes, sir.
Yes,
Yeah,
yes.
yeah, go ahead.
Yeah, sorry. So I was telling that it is not a
Yeah,
very
you are audible. Yes.
it's not a very radiosensitive tumor also, and in my opinion, this is purely an exercise in palliation, and I don't think radiotherapy, even in palliative setting, is going to help this patient much.
Right. So, Areej, what is it that you would do in a joint clinic discussion in this patient?
Sir, because considering his age, sir, we'll start with 3 weekly course. I mean, 3 weekly, 3 cycles of.
No. How will you present this to a joint clinic? Now we are a joint clinic here. Do you have a
Yes.
radiation oncologist? We don't have a medical onc here. So what is it that you will do in order to help this patient?
So because we can plan him for neoadjuvant chemotherapy, sir, with
So what chemotherapy
cisplatin.
protocols would you give, or what chemotherapeutic agents will give this patient?
Sir, cisplatin, docetaxel or with 5-fluorouracil, sir, 3 cycles.
Areej,
Yes.
as sir has asked, how would you present in the tumor board that, or how do you sort of tell your medical oncologist to convince them to give anisite in this patient?
Sir,
Because
he is a young patient. He has no other comorbidities, and he has vision of only one eye, and he is already having compressive symptoms of the opposite eye. So, and he has an eco 0 performance scales patient, so we can consider him for.
but if I being a medonc, I tell you okay, it's not a chemosensitive, so this will not help much. And yeah, this will not help much because we know it's not a chemosensitive tumor, not much. So how would you argue in pushing them to give chemotherapy? Because you were saying that you will want to give a NACT, that to 3 drugs NACT, correct?
Yes, sir. Because of his.
Because this is what we face. So
Yes.
how do you push them to give NACT?
I would say he's young patient, good performance score, and for his vision, I think we should take a chance to preserve the opposite eye.
Okay.
So I would argue the other way also.
Yes.
If this
Yes.
patient, the medical oncologist tells you it is not chemosensitive, my radiation oncologist tells you it is not radiation sensitive. surgically this is not operable. So you are left with almost nothing to offer this patient. So what would you do next in this patient? What would you then like to do in order to determine what would be the next step?
So we can try for PDL1, but then
Yeah, so you will want to look at other forms of
forms of immunotherapy.
other forms of therapy possibilities.
Yes.
So you would need to study the tumor in more detail. You would process this with your molecular pathologist for whole genome sequencing or next generation sequencing.
Sure.
You would like to ask for whatever targetable drugs are available with your center, with the medical oncologist, and look at those targets. So these are not things that are feasible in
So
all centers, but you being in a tertiary cancer center, you should consider doing that.
yes.
Whilst you're doing that, how will you break the news to this patient that he is not curable?
Sir, I'll explain to him that the tumor has presented very late. He has presented to us very late stage of the tumor, and we can try next genomic sequencing and other new possibilities of immunotherapy.
Right,
But the chances of cure are going to be less.
right,
And I'll make sure that he has a good support system
right.
at home, and to that he might have. I'll tell him that there is a chance of loss of vision of the opposite eye as well, and
So you need to learn how to do break bad news to the patient.
yes, sir.
And whilst you're doing that, you need to offer the patients palliative care uh, and psycho-oncology.
Yes,
So all these things have to be done simultaneously. So whilst you're waiting for the next generation sequencing or molecular pathologist to tell you if there's any targetable mutations, all these things have to be considered.
yes.
Would you consider giving palliative radiation?
Uh, yes, sir. We, we can attempt, sir, this case.
Mhm.
How would it benefit? Palliative radiation, how would it benefit?
It is not very radio sensitive, but
No, in this case, if palliative radiation can even be detrimental, because of the initial edema and just based on its location, whatever
Yes.
remaining useful vision he has on the contralateral side, that can also be hampered, right? So I'll be very careful in suggesting palliative radiation for this patient. In fact, I will 9 times out of 10, I will not do palliative radiation for this patient.
Right.
Right.
So I think that's a very fair statement Dr. Shwetabh made, that we always push for the other faculty to take over because we have nothing to offer. But very often we need to look at the patient as an entirety and then understand and discuss with the group what would be in the patient's best interest. So as of now, like you said rightly, anti-edema measures, pain management, focusing on offering the patient nasal something to prevent bleeding from the nose. Those are the things that you would want to consider in this patient, whilst you are trying to think of what other strategies can be offered. So this is something that is beyond the purview of all of us in this case. Deepa, any thoughts? Deepa's there.
Yes, sorry, I'm in and out because of this
Yeah.
network.
That's fine. Any new things that are there in the nut midline spectrum that
Unfortunately, not so much. Some reports of trying immunotherapy, but really, this is a space which needs further investigations. The number of cases are so few that literature itself is so sparse.
so
We
there
looked
was
at some of our cases, and
yeah
offhand, I can tell you that around 9 cases, I think we operated, and 3 or 4 are alive without disease, but the rest have all, succumbed to disease. And even if you give them CTRT, the outcomes are dismal.
So these are very aggressive tumors.
From what I remember, with a couple of patients we started doing definitive CTRT. I remember 2 cases who have progressed on CTRT while they are on CTRT. And we
Right.
had to stop. I remember 2 of these cases.
So there was a couple of papers that have come up which have looked at what is the derivative cell of the nut midline, and they are reclassifying it as a very aggressive squamous cell cancer. So we are seeing this mutate fusion, and we are calling this a nut midline. And so we need to consider giving aggressive chemotherapy based on the fact that it could have a squamous cell origin, and some of them might respond. But overall, everybody agrees that this is a very aggressive tumor with very poor prognosis. And as Deepa has discussed, the outcomes are poor whether you operate or even give radiation. So in a clearly operable disease, yes, you would consider doing aggressive surgery and aggressive radiation, but overall prognosis remains poor. So what did you do for this patient, Aris?
Sir, currently he's undergoing his NACT, sir.
Okay. And what drugs have you all started him on?
Sir, he's on cisplatin, docetaxel, and 5-fluorouracil, sir.
Okay. Anything else? Any other thoughts? Kaberi, Shwetabh?
Yeah. So how many cycles did he, just being curious, how many cycles did he finish?
Ma'am, 2, ma'am.
Any response?
Ma'am, the repeat imaging has not done. His vision is still okay of the right side, ma'am. But
Okay, Mana, it's
ma'am,
like
it has not
before,
deteriorated. It has not deteriorated, ma'am.
but it has not come down as you were expecting, no?
Yeah.
With chemo, we might be able to preserve the other eye.
Yes, ma'am.
Okay, okay. So what are your plans if it's stable disease, or if it is come down? I mean, it has come down. I mean, the size has come down, number one, and number two, if it is a stable disease, what are your plans next after NACT?
Ma'am, both case, ma'am, he will not be operable, ma'am. So mostly
Yes, and then what?
he'll be kept on then chemotherapy also, ma'am, palliative chemotherapy.
Because if with 2 cycles he's not showing much response, there's very less chance he'll respond to the third cycle.
Third cycle, yes, ma'am.
Right. Okay.
Okay. I think you presented well, Areej. Focus on trying to arrive at a conclusion from your history taking, which will guide you towards a more definitive questioning of the patient.
Yes, sir.
Try to avoid giving very generalized negative history and a negative past history.
Yes, sir.
Focus on first thing you need to do in skull-based tumors is try to arrive at a diagnosis and localize the tumor.
Sir.
And then once you have an understanding of the histology, look at the imaging from the perspective, is it a treatable disease? Generally, in these tumors, if it is operable, it is curable.
Okay, sir.
Generally. So first of all, when you're looking at the imaging, you need to look at what are the sites where you can potentially fail. And if it is in those areas, you will not be considering surgery. And
Sir.
again, histology rules. So there are a lot of histologies which are chemosensitive in the paranasal sinus tumors. So if you determine that this is not operable and the histology is favorable, you would consider neoadjuvant chemotherapy to downsize it and then offer this patient concurrent chemoradiation to control the disease.
Yes, sir.
So look at it critically. The imaging has to be looked at from the perspective of inoperable to operable.
Sir.
And then from operable, whether it is minimal access to an open approach.
Okay, sir.
Kaberi and Shwetabh, any thoughts? Deepa?
No, sir, that's all from me. Areej, you presented well,
Thank you.
presented quite well.
I agree. You presented very well.
Kasim?
Yeah, okay. Thank you. Thank you so much, Areej, for the presentation.
Thank you, sir.
And thank you, Paisal. Thank you, Deepa ma'am, for the excellent lecture. Thank you, Shwetabh, Kaberi, and Smriti for joining. And thank you, everyone, for joining. The next session will be on thyroid malignancies, and we'll be discussing the trends of thyroid malignancies in that. So we'll welcome you on the 1st of January 2026. We'll see you in next year. And thank you, everyone, for joining.
Thank you very much. All the best.
Thank you.
Thank you. Bye.
Thank you.
Bye. Bye, Deepa. Bye.
Thank you.